We've got a long list of potentially good contributions, so let's give them time. It's Ghana, followed by Senegal, then Mali. Is Ghana here? Yep. Sorry, Ghana. It's actually Cote d'Ivoire first, then Ghana. Thank you, Vice Chair. Cote d'Ivoire, you got the floor.
Okay. Merci, Monsieur le Président. Monsieur le Président, la Côte d'Ivoire félicite l'Organisation mondiale pour la santé, AFRO, pour la qualité de ce document. Devant l'émergence de la fièvre jaune et les autres fièvres hémorragiques, le gouvernement ivoirien a initié des actions interministérielles pour lutter contre leur expansion. Plusieurs initiatives ont été réalisées, notamment l'investigation épidémiologique et entomologique autour des cas que nous avons eus et l'évaluation périodique du risque amaryle à travers des enquêtes entomologiques en dehors même des périodes épidémiques, la recherche active des cas secondaires, la prise en charge des cas bien sûr, la vaccination de l'entourage immédiat des malades et des campagnes de vaccination contre la fièvre jaune, des campagnes qui sont faites de façon systématique aux frontières, aussi bien aux frontières terrestres, aux frontières aéroportuaires. Il y a également le renforcement de la surveillance épidémiologique dans tous les districts de Côte d'Ivoire. L'organisation des réunions régulières de suivi de l'évolution de la situation en collaboration avec les autres ministères conformément au concept One Health. C'est ainsi que nous venons tout dernièrement à la date du 25 et à la date du 15 de faire un exercice de simulation au niveau du centre d'opération d'urgence pour tester notre capacité de réponse. Et l'exemple que nous avons pris, c'était l'exemple d'une épidémie de fièvre jaune. Cela nous a permis de voir notre niveau de réaction et de montrer qu'en pareille circonstance, nous pouvons réagir promptement et surtout efficacement. Il y a également la lutte antivectorielle. Et au niveau de cette lutte antivectorielle, nous avons pris en compte surtout l'identification et l'élimination des gîtes larvaires avec la collaboration des populations. Et ce n'est qu'après ça que nous passons pour faire l'élimination des moustiques adultes par la fumigation. Cela a été apprécié par la population qui a compris désormais qu'elle a une part importante dans la lutte contre les arboviroses. La Côte d'Ivoire réaffirme son adhésion à la résolution et adhère pleinement au point 10 en rapport avec l'inadéquation et la rigidité excessive des stratégies de vaccination qui souvent est à l'origine des occasions manquées de vaccination. Par ailleurs, la Côte d'Ivoire est préoccupée par souvent la réticence de certains passagers aux frontières aériennes surtout quant à la vaccination. Et nous pensons que cela doit être compris de tout le monde pour éviter de transférer des cas dans un autre pays conformément au règlement sanitaire international. Monsieur le Président, la Côte d'Ivoire voudrait remercier toute l'Assemblée et vous remercier pour la parole que vous lui avez donnée. Je vous remercie.
Thank you, Côte d'Ivoire. It's quite interesting the issue you mentioned about larviciding. It will be interesting to really learn how the community, you said, is doing larviciding. But very important important points that you've raised here. Ghana, followed by Senegal.
Thank you, Chair. Ghana welcomes the report of the Secretariat and commends them for the preparation of the regional implementation framework. For all the epidemics that the African region faces, yellow fever is perhaps the one we stand to make major gains with rigorous immunization that lasts a lifetime. Africa remains endemic of yellow fever, and the sudden effects of climate change means we should brace up for sporadic outbreaks. We believe the global health strategy to eliminate yellow fever epidemics provides a necessary plan to protect the populations most at risk, ensure a ready supply of yellow fever vaccine, build resilience in urban centers, and prevent international spread. We therefore welcome the priority interventions and the proposed actions in the framework for implementing a strategy to eliminate yellow fever epidemics in the African region and support its adoption. Mr. Chair, Ghana is implementing the Yellow Fever Initiative with support from Gavi Vaccine Alliance through preventive mass immunization, in addition to routine immunization for children. We have established case-based yellow fever surveillance, as well as strengthened capacity building of our national laboratories for serological screening and laboratory confirmation. We are also undertaking strict routine checks at all our ports through the application of the international health regulations. I believe the Chair, Honorable Minister of Health of Zimbabwe, would attest to this, as he was vaccinated some time back, precisely about a year or two ago, when he could not produce his vaccination card upon arrival at the Kotoka International Airport in Accra. Just similar exercises has resulted in the ambassador from Denmark visiting my office complaining about visitors from Denmark to Accra being forced to immunize for the vaccines when they could not produce their yellow cards. This notwithstanding, as a yellow fever endemic country, cases are reported annually, and these are interspersed with focal outbreaks despite our efforts. In 2015, Gavi approved 6 million vaccines for mass vaccination campaigns for 64 at-risk districts, which was suspended due to certain technical challenges and vaccine shortages as a result of outbreaks elsewhere on the continent. Ghana is currently considering mass YF immunization campaigns for the first quarter of 2018 for 74 at-risk districts that were previously left out of campaigns. However, being a country in the transition phase of Gavi support, we require support with staff training, vaccine quality management, and other related capacities. I thank you, Mr. Chair.
Thank you, Ghana. Indeed, I can attest to that. I was in transit through your airport, and I could not produce my yellow fever vaccination certificate from Zimbabwe. And I tried to explain that I'm a minister of health. And I was told, come, they took me to a private room there and indeed vaccinated me at the airport. So yes, you've got very rigid. That's very good. That's very good. Thank you very much, Ghana. It's Mali, followed by Togo. Mali, you have the floor. Jump.
Merci, Monsieur le Président. Le Mali félicite le secrétariat pour la qualité des documents soumis. Le Mali avait approuvé l'intervention du président du sous-comité du programme au comité régional au point 6 hier. Le président du sous-comité avait mis l'accent sur dans le cadre de la fièvre jaune, avait mis l'accent sur l'inclusion des coûts opérationnels, les modalités de financement et la disponibilité des vaccins. Et par rapport à cette disponibilité des vaccins, nous souscrivons à tout ce qui a été dit quant au problème de rupture récurrente dans nos différents pays. C'est pourquoi le Mali apporte son soutien à l'adoption de ce cadre pour la mise en œuvre de la stratégie nationale mondiale pour l'élimination des épidémies de fièvre jaune 2016-2026 dans la région africaine. Le Mali s'est réjoui que le document déjà déclare au niveau de sa page 3 que le déficit de capacité reste un défi. Effectivement, nous avons une préoccupation à ce niveau, notamment la disponibilité des réactifs pour le diagnostic biologique de la fièvre jaune. Monsieur le Président, ces réactifs sont fournis par l'OMS. À la suite de ces lectures récurrentes, nous avons saisi le bureau régional, mais sans succès. Le bureau local du moins, sans succès. Nous voulons poser ce problème sur la table ici. Si dorénavant aussi on peut améliorer la disponibilité des réactifs afin de pouvoir faire le diagnostic biologique. Et je pense que cela peut aussi permettre une surveillance efficace des épidémies de fièvre jaune. Je vous remercie.
Thank you, Mali, for supporting this paper. In fact, it was meant to be Senegal, then followed by Togo. Senegal, you have the floor.
Merci beaucoup, Monsieur le Président. Le Sénégal remercie le secrétariat d'avoir inscrit ce point à l'ordre du jour et a pris bonne note donc du rapport, mais tient à attirer l'attention de l'OMS sur les enjeux et défis, notamment d'ajouter au point 10 la nécessité de proposer une alternative capable de corriger la rigidité excessive de la vaccination systématique des enfants qui, une fois l'âge vaccinal atteint pour cet antigène, autour de 9 mois, ne reste que 2 mois dans le programme de vaccination sans aucune autre stratégie de rattrapage alternative. Les enfants à l'âge de 9 mois n'ont que 2 mois pour rester dans le programme et vont sortir et peuvent avoir des occasions ratées. C'est une première faille dans la routine. Au point 11, il y a la nécessité également d'encourager et de soutenir la production de vaccins anti-amaril. L'Institut Pasteur de Dakar, qui est une fondation sénégalaise, et produit également des vaccins. Donc cette production est actuellement insuffisante pour couvrir les besoins de vaccination de routine, les flambées notées, la couverture des voyageurs et autres migrations, que ce soit des pèlerinages, déplacements des contingents militaires par ailleurs dans le continent. Enfin, pour conclure sur toujours cette stratégie, sur un plan plus général, cette stratégie qui vise l'élimination des épidémies de fièvre jaune dans la région africaine doit être globale et mieux coordonnée pour en fait être à l'image des autres campagnes comme les campagnes des épidémies de lutte contre les méningites A, les campagnes de suivi contre la rougeole ou bien les campagnes de lutte contre la poliomyélite avec bien sûr des composants, des variantes sur le plan opérationnel et organisationnel. Je vous remercie de votre attention.
Senegal, for supporting the paper. It's now Mali, followed by Togo, followed by Sao Tome. Yeah?
Merci, Monsieur le Président. Le Togo félicite le secrétariat pour la qualité des documents techniques qui sont mis à la disposition des délégués à ce comité régional. La récente épidémie de fièvre jaune en Angola et en République démocratique du Congo en 2016 prouve que nos pays restent vulnérables si rien n'est fait pour améliorer la couverture vaccinale anti-amaril. La vaccination anti-amaril n'est pas intégrée à la vaccination de routine dans tous les pays dans la région africaine. Ainsi, la faible couverture vaccinale, couplée à la mise en application non optimale du règlement sanitaire international, les bouleversements des écosystèmes induits par l'activité humaine favorise la survenue des épidémies. Au Togo, le vaccin anti-amaril est introduit dans le programme élargi de vaccination et la couverture vaccinale était de 86% en 2016 auprès de la cible. Le système de surveillance est mis en place et fonctionnel au Togo. Nous voudrions ici remercier l'OMS et tous les partenaires pour les différents appuis apportés pour atteindre les performances observées sur le terrain. Monsieur le Président, s'agissant du cadre de mise en œuvre de la stratégie mondiale pour l'élimination des épidémies de fièvre jaune, le Togo partage les défis et enjeux qui y sont évoqués et trouve pertinentes les cibles et interventions et actions prioritaires proposées. Le Togo approuve le cadre et appelle à l'adoption des interventions et actions prioritaires qui y sont proposées. Je vous remercie, Monsieur le Président.
Thank you very much, Togo, for supporting this paper. Sao Tome and Principe, followed by the United Republic of Tanzania.
Obrigada, Sr. Presidente, pela palavra. Em São Tomé e Príncipe, a taxa de incidência é zero, quer dizer que é risco zero. Com a epidemia em 2015 e 2016 em Angola, foi atualizado o plano de ação e resposta à febre amarela em São Tomé e Príncipe. Mas, porém, nós temos uma fraqueza. Existe o Departamento da Vigilância Epidemiológica que faz controle de entrada e saída de viajantes em São Tomé e Príncipe, conferindo se tem vacinas ou não. Mas temos uma preocupação, é que caso tenhamos ou venhamos a ter um caso suspeito de febre amarela, nós não temos como confirmá-lo, porque as amostras que pudermos colher já não poderão ser enviadas para Yaoundé via DHL, porque o São Tomé e Príncipe foi interdito de enviar produtos perigosos por DHL, e nós ficamos com uma grande preocupação. E estaríamos aqui a pedir à OMS Afro que desse uma especial atenção a esse problema, que julgo não ser só São Tomé que tem esse problema de interdição de envio de amostra por HDL. A febre amarela, a vacinação, entra no nosso calendário de rotina e é feito aos 9 meses. Até então, nós temos tido boa cobertura, temos uma cobertura de 93%. Tendo em conta a importância desse documento, São Tomé e Príncipe apoia a implementação estratégica para a eliminação da febre amarela em África. Eu queria chamar a atenção para o anexo, estava a ler o anexo 1, onde diz que São Tomé, aparece o N à frente de São Tomé, como que a vacinação de rotina não faz parte. Quero informar que vacinação de rotina faz parte do nosso calendário em São Tomé e Príncipe. Obrigada.
Obrigado. And you notice here that the issue of the ban of on DHL, our regional director, I think, they are asking for your assistance there. Thank you. United Republic of Tanzania, followed by Democratic Republic of Congo.
Thank you very much, Chairperson. Tanzania welcomes the 2017-2026 framework for implementing the global strategy to eliminate yellow fever epidemics, which has summarized well the targets and milestones and emphasized on a single dose of yellow fever as a quick public health gain to eliminate yellow fever epidemics. This is a long-awaited strategy based on the fact that Africa has been experiencing frequent yellow fever epidemics. Hence, having an elimination strategy and a clear roadmap to attain the goals of the strategy in the region is important. We believe if the strategy with its objective and targets is addressed well in the region can be made free of yellow fever epidemics. Although Tanzania has not reported any case of yellow fever among humans since 1950s, it is among the countries in East Africa which is at risk because it lies in the yellow fever endemic regions. Efforts are in place to strengthening yellow fever surveillance through the integrated disease surveillance and response system and vaccinating international travelers. Chairperson, new revised yellow fever certificates for travelers has been introduced in 2017 to minimize counterfeit certificates. In October 2017, Tanzania is planning to conduct the yellow fever assessment aiming at determining the yellow fever virus circulation so as to provide important information for developing evidence-based strategies to predict and control the yellow fever in the country. Chairperson, the key priority interventions and actions mentioned in the strategy require clear roles to be differentiated between member states and the WHO and partners. We would like this to be well described in the document. We would also like an addition of a component on monitoring and evaluation in the strategy to oversee progress made towards the attainment of the targets set out in this strategy, and proposed that this be added as an agenda item in the next regional committee's meeting. Lastly, Chairperson, we would like this strategy to be aligned with the recently adopted Global Vector Control Response Strategy during the next World Health Assembly so as to align the vector control activities highlighted in the response strategy with this eliminate yellow fever epidemic strategy. Chairperson, Tanzania, like previous speakers, endorses the strategy to eliminate yellow fever epidemic, and it is priority interventions and actions. I thank you very much, Chair.
Thank you, my sister. I think clear, but you brought in a new issue here of counterfeit certificates. I think that's something that we need to be very alert to, and the clear roles between WHO and partners. I think you've brought that out very clearly, and of course the vector control integration but also monitoring and evaluation in the strategic agenda. So those are very key areas. Thank you, Tanzania. DRC followed by Guinea.
Merci, Monsieur le Président. Reconnaissant la qualité du document et sous examen et se joignant à tous les autres États qui demandent son adoption, la République démocratique du Congo, pays à risque d'épidémie de fièvre jaune, prend la parole juste pour 3 choses. Premièrement, c'est de se saisir de cette opportunité pour présenter encore une fois ses remerciements à l'OMS et à tous les autres partenaires pour leurs appuis respectifs importants lors de la riposte contre la dernière épidémie de la fièvre jaune qui a affecté en 2016 aussi bien Kinshasa, la capitale, une ville peuplée de plus de 10 millions d'habitants, que 2 autres provinces frontalières de la République sœur de l'Angola. La deuxième chose, Monsieur le Président, c'est de porter à la connaissance de l'auguste Assemblée que les résultats partiels de la recherche en cours à l'Institut national de recherche biologique situé à Kinshasa sur l'immunité et l'efficacité obtenue par l'administration de la dose fractionnée pendant la dernière riposte préventive en 2016 est en train de montrer que l'immunité ainsi acquise est la même qu'avec la dose complète. Nous restons encore suspendus au résultat définitif de cette recherche. Pour terminer, Monsieur le Président, c'est de suggérer au secrétariat relativement à la partie ayant trait aux interventions d'ajouter les actions de recherche pour la résolution de la problématique de la production et de la disponibilité du vaccin anti-amaril. Voilà, Monsieur le Président, tout. Encore une fois, merci.
Thank you, DRC. The issue of research and dosages, partial or full dosages. I think we all await that research, and of obviously manufacture and availability of vaccines is key. Our last country delegate speaker is Uganda. Guinea followed by Uganda.
Merci, Monsieur le Président. La Guinée félicite le secrétariat pour la qualité du document produit. Monsieur le Président, la fièvre jaune fait partie des maladies prioritaires à potentiel épidémique surveillées en République de Guinée. Le seuil d'alerte est atteint avec un cas suspect et le seuil épidémique avec un cas confirmé. Le renforcement de la surveillance épidémiologique en Guinée a conduit à la notification depuis la semaine 46 de l'année 2016 des cas de fièvre jaune dans 4 préfectures de la Guinée. Également, au cours des 4 premières semaines de l'année 2017, des cas de fièvre jaune ont été rapportés par les équipes préfectorales. Ces cas ont été confirmés par le laboratoire national de fièvre hémorragique de Conakry et par l'Institut Pasteur de Dakar. Ces cas, pour la plupart, étaient des cas vaccinés et n'ont pas entraîné des épidémies. Néanmoins, des ripostes locales en ceinture avaient été organisées dans 2 de ces préfectures. Il y a aussi eu de la fumigation dans les localités avec un indice de Bretto supérieur à 5%. En plus, une mission conjointe d'investigation approfondie composée de l'OMS Guinée, IST, Afro et du siège de Genève, naturellement avec le ministère de la Santé, a été conduite dans les zones concernées pour évaluer le risque épidémique et le potentiel de propagation au sein du pays et au-delà des frontières. Cette situation montre que la Guinée est en phase avec les activités de détection et de riposte contre la fièvre jaune. Cependant, le risque d'une épidémie ne peut pas être écarté car l'environnement est propice à la multiplication du vecteur. La faune susceptible de constituer un réservoir est aussi présente et aucune étude n'a été faite localement pour mesurer la présence du virus dans la faune sauvage. Des gaps pour une lutte intersectorielle existent aussi en attendant de voir la mise en œuvre des plans du REDIS, qui est un Reginal Disease Surveillance and Enhancement Project au niveau de la sous-région, du One Health et de l'agence de sécurité sanitaire et de l'agenda de sécurité sanitaire, le Global Health Security Agenda. En conclusion, Monsieur le Président, la Guinée soutient l'adoption des interventions et actions prioritaires proposées dans le cadre de la mise en œuvre de la stratégie mondiale pour l'élimination des épidémies de fièvre jaune 2017-2026 dans la région africaine. Je vous remercie.
Thank you, Minister from Guinea. Vector control and the issue of cross-border controls, and also the issue of One Health. It's key in terms of managing infections that come from animals. Uganda is perhaps our last.
Thank you, Chair. Chair, Uganda has had about 4 outbreaks of yellow fever, the first being in 1942. Then we had another in the 70s, 2010, and 2016. And therefore, we do welcome and thank the Secretariat for this framework paper and its proposed priority interventions. The recent appearances of the yellow fever in some African countries, including Uganda, with potential for more spread, is particularly worrying. we have not fully utilized the vaccination as a tool for prevention, and this is something that we need to pay attention to. Changes in demography and land use patterns in Africa have created ideal conditions for explosive outbreaks of urban yellow fever. We have had a safe, low-cost, and effective vaccine that confers lifelong protection against yellow fever for over 80 years, and that is since 1937. And the current yellow fever vaccination confers lifelong protection and should be and must be used more widely to protect the people living in the endemic countries to achieve optimal vaccination coverage. We have a challenge, as mentioned by the previous speakers, Chair, that yellow fever vaccination is not included in our routine immunization program and is only left for the international travelers, and this approach needs to be changed. WHO Chair recommends vaccination of populations in order to prevent the risk of yellow fever transmission. We, however, Chair, have a challenge globally of the vaccine stockpiles, which are limited, and of course this is a hindrance to, maybe a hindrance to our target of eliminating yellow fever by 2026. If these vaccines could be available, there would definitely be no reason why we cannot deal with this epidemic and totally eliminate it from the African continent. Chair, we cannot afford to be complacent with 440 million of our people at risk, and therefore the yellow fever vaccination must be in the routine immunization schedules, as I mentioned, and of course in addition to the mass vaccination campaigns that we have had in our countries. In the outbreaks, the most recent was in one of the parts in southern Uganda, and we have had to have a mass vaccination in this area. But of course, even then, we still had to wait for some time before we got all the vaccines that we needed due to its limited availability. So the importance of the One Health approach involving all relevant stakeholders cannot be overemphasized, and this has been mentioned also by the Minister from Guinea. So we want to call for and support the current initiatives for ensuring enough vaccine supplies for yellow fever prevention, commitment to the implementation of the international health regulations, and this must be a priority as yellow fever is a significant health security risk. Chair, Uganda therefore endorses the adoption of the priority interventions in the framework, and of course the issue of the counterfeits has also been dealt with by Uganda recently, just about 3 months ago. We also issued new yellow fever vaccines, cards, because we realized that there were counterfeits around the place. Thank you, Chair.
Thank you, Uganda. Again, more proficient use of vaccination against yellow fever, and the issue of including yellow fever as part of the routine immunization program in our countries. Ministers, heads of delegation, I think we've covered those who wanted to speak. I will now ask the Secretariat through Dr. Yoti to make a response.
Thank you very, very much for those very comprehensive comments, which are really supportive and quite encouraging. I'm overjoyed by the overwhelming support for this paper. Many of them were really comments, and I will respond to just a few of them. The area of integrated vector management. You all clearly highlighted the need to sustain our efforts in ensuring that we maintain low mosquito density. Mosquitoes are not only for yellow fever, the risk for chikungunya, Zika, dengue, malaria, and others. So that is a key point. What is unique with yellow fever, the biggest hope is that there's a vaccine which confers lifelong immunity. So that's why we so much emphasize the vaccination in this area. But on page 6, we have noted the need to sustain the efforts for vector control. My second point is we will really not need to do reactive vaccination. We will not need to do catch-up vaccinations if the routine vaccination coverage is maintained at a very high acceptable level. Therefore, the emphasis you have laid on routine vaccination is key, and if we can make this practical, especially if the vaccine shortage is not an issue, and the proper risk assessment for yellow fever is done, and we know areas where we should vaccinate children at a very early stage, maintaining very high levels of routine vaccination. And lastly, Chair, the issue of improving on diagnosis. In this document, in the next 10 years, we plan that currently there is one reference lab for African region. By 10 years, we should be able to have 6 reference labs. Moreover, we will have the local labs able to do some of the tests available as well. Finally, the research issue, I think you highlighted, we have taken note of that. We eagerly all await for the results from the fractional dose which we used in Kinshasa, and the follow-up. This is the second year of the follow-up. As the delegate from, as the minister from DRC said, after 1 year, the results are so far promising. So we look forward to really getting a lower dose, which will be really cost-effective, and will minimize the stock out of vaccines. Finally, I just hope that RSC 77, which is 10 years now, 2027 will be celebrating the end of, will have eliminated yellow fever outbreaks in African region and also globally as well. Thank you so much.
Thank you, Dr. Yoti. 10 years indeed. Regional Director.
Thank you, Chair. No, it's simply to thank the honourable ministers and delegates for all your contributions, suggestions on how to strengthen this this strategy. I will not add any more. I think just to appreciate the fact that we are all recognizing that if we do certain things, improve the inclusion and coverage of yellow fever and routine immunization, carry out the strategy for campaigns targeting countries at risk, then we could really eliminate epidemics of yellow fever in the region. Thank you very much.
Thank you, Regional Director. Distinguished delegates, shall we take it that the Regional Committee is ready to adopt the priority interventions and actions proposed in document AFR/67/8 on the framework for implementation the global strategy to eliminate yellow fever epidemics 2017 to 2026 in the Africa region, taking into account comments made. I think it is so decided. The proposed priority interventions and actions are adopted. Having said that, I will not now pass the floor to Ms. Cynthia Genolet to make a statement on behalf of the International Federation of Pharmaceutical Manufacturers Association. Ms. Genolet, you have the floor.
Thank you, Mr. Chairman. Honorable Chair, distinguished delegates, thanks for the opportunity to contribute to this important discussion today. IFPMA represents leading research-based pharmaceutical companies as well as national and regional industry associations across the world, including 2 in Africa. IFPMA commends the strategy to eliminate yellow fever epidemics, which brings renewed vision and energy to controlling yellow fever across the world by reducing the risk posed by an urban foothold of the disease. We were glad to be a part of the discussion and development of the strategy with the WHO and the Gavi Alliance through our member company. Endorsement by the WHO Strategic Advisory Group of Experts, SAGE, on immunization and financing by Gavi sends a strong signal encouraging countries to move forward and implement the strategy. Uniquely, a single dose of yellow fever vaccines offers lifelong protection and is supplied to UNICEF at a very low price. So, although we cannot eliminate this disease, we clearly have the tools to control it. We are committed to providing a reliable supply of high-quality, effective vaccines to meet the anticipated need. Manufacturers plan to be able to supply significantly increased yellow fever vaccines volumes through to 2026. In the case of IFPMA, this is thanks to a private investment one of our members has made in constructing, validating, and bringing online a new manufacturing facility. Responding to the yellow fever outbreaks in 2016 and 17 was a significant challenge for all of us. Specifically from a vaccines manufacturing perspective, the unpredictability of the surge in demand is one of the most difficult areas to manage. As we all know, quality-compliant vaccines take many months to manufacture and control, and there are no shortcuts to making safe vaccines. Accurate demand forecasting by countries to ensure sufficient supply is a key component to success. These latest outbreaks demonstrated that we must do better as a partnership to ensure strong uptake of yellow fever vaccine as a part of the expanded program on immunization, as well as implementing successful catch-up programs, thus greatly reducing the risk of outbreaks. Thank you for your attention.
Thank you very much, the delegate from IFPMA. I think with that, we move straight to agenda item 13, which is a framework for health systems development for universal health coverage in the context of the Sustainable Development Goals in the Africa region. And it is document AFR/67/10. And this issue of universal health coverage, we just came from a lunch side meeting, which was almost talking about the same thing. But I know we've got people here in countries that are passionate about this. I won't mention names yet, they'll put up their flags. Let's talk about this. So, to introduce us to this topic, we'll ask the Director Health Systems and Services Cluster, Dr. Dovlo, to lead us in this discussion. Dr. Dovlo, you have the floor.
Thank you, Mr. Chairman. On behalf of the Secretariat, I have the privilege to introduce the document, as you've mentioned, AFR/RC67/10, which we have entitled the Framework for Health Systems Development Towards Universal Health Coverage in the context of the Sustainable Development Goals in the Africa region. The purpose of the document is provide guidance to member states' efforts to strengthen their health systems and help us facilitate achievement of the universal health coverage, and from there, the Sustainable Development Goals. I would like to refer to very briefly to some key points in the paper. The paper starts with a context, and this context describes the great improvements that have been made in health outcomes for our population over the past 20 years, with increases in life expectancy, decreases in adult and child mortality rates and maternal mortality ratio, and these have come from better availability of services, increasing coverage of key interventions like antenatal care and skilled birth attendants. These accelerated during the MDG era. There has also been increases in per capita total health expenditure and in government's health expenditure. The framework was developed at a technical forum in Windhoek that examined what practical actions we could take to implement the global commitment to universal health coverage and the Sustainable Development Goals by our member states. It aims to shift us from tackling systems as vertical building blocks to a more integrated and holistic approach that produces the goals we want to achieve of healthy lives. The key issues we highlight in the paper include the emerging challenges in the region, the dual burden of disease, the demographic, economic, social, environmental, and security challenges that have placed an increased burden on health systems or will place an increased burden on health systems in the near future. And therefore, we need to prepare adequately and have well-programmed investments in the region, and we'll need to empower communities to participate fully in their health development. The framework proposes options for priority actions, including to countries' contexts, to guide comprehensive and integrated health systems investment to expand availability, coverage, and resilience of health services. We need to scale up financial risk protection, improve client satisfaction, and address, as already mentioned, the health security challenges. Also important is that it proposes measures for monitoring health systems performance and results in a way that includes resilience, access, quality, and ensures that we monitor effective demand and utilization of services. It is my duty on behalf of the Secretariat, therefore, to submit this document to the Regional Committee for its review, advice, and adoption. Thank you, sir.
Thank you, Dr. Volvolo. Thank you very much, because you have summarized it well. And now I invite honorable ministers, heads of delegations, to make their contributions. Where are we? Cameroon, Zambia, Namibia, the Gambia, Malawi, we've said, Senegal,
DRC,
Burkina Faso, DRC, Equatorial Guinea, Nigeria, Ethiopia, Kenya, Liberia, Ghana,
Zambia too.
Yeah, we've mentioned it. You hadn't written it down. Okay. What about yes, South Africa? Yes. Okay. Let's start. We'll start here with Zambia, followed by Malawi.
Thank you, Chair. Mr. Chairperson, Your Excellencies, fellow delegates, ladies and gentlemen, it is an honor for me to take the floor on behalf of the government of the Republic of Zambia on this agenda item, and would like to state from the outset that achievement of universal health coverage is a key aspiration of the Zambian government, as it is target 3.8 of the SDG goal number 3. We thank the Secretariat for their work in developing this framework, and also wish to acknowledge the leadership of the new WHO DG, who has clearly stated that all roads will lead to universal health coverage during his tenure of office, and we applaud this. Mr. Chairman, the development of framework for systems development towards universal coverage in the context of sustainable development goals in the African region is not only timely, but also strategic. It is in line with our joint commitment to strengthen our health systems, strengthening the primary level of the healthcare system to better respond to our people's health needs. While momentum is peaking to move forward towards this goal, we urge the WHO and other partners to ensure coherence in policies and programs that are put in place to lead us to this goal, and not pick and choose while leaving out certain areas of our health system delivery. In this regard, we wish to remind all of us that the World Health Assembly in 2015 or the 194 endorsed Resolution A68.15 on strengthening emergency and essential surgical care and anesthesia as a document for universal health coverage. This resolution was further endorsed through Decision A70.22 at the just passed 70th World Health Assembly. Thus, going forward, we would like to see integration of all policies and programs that are part of our work towards attaining universal health coverage in the African region. At national level, Zambia continues to develop policies and implement programs with universal health coverage as our guiding principle. The Zambian government therefore remains committed to achieving universal health coverage in Zambia and also stand ready to support and work with other member states and development partners towards this goal. I thank you, Mr. Chairman.
Thank you, Zambia, for supporting this important document. Malawi, followed by Cameroon.
Thank you very much, Honorable Chair and Honorable Ministers. Malawi is in support of the proposed framework, and in this case, universal health coverage. We have a health system that addresses the same. We've just launched the Malawi Health Sector Strategic Plan 2017 to 2022, which is addressing universal health coverage. And the Malawi government has outlined healthcare interventions available to all Malawians, free at the point of access, with the aim of achieving universal health access to quality health care, irrespective of the ability to pay. In areas where there are no government facilities, but private or Christian Health Association facilities, service level agreements have been signed to make sure that people access services for free from such a facility. We have a well-organized system with posts in the communities, dispensaries in the communities, health centers, community hospitals, district hospitals, and central hospitals. And for one, to access services at every level, there is a referral system to the next. The presence of community health workers known as health surveillance assistants is a clear indication that we are indeed in support of the universal health coverage. And the intentions of government is to have one health surveillance assistant for every 1,000 people. And I'm glad that there's a document endorsed by our heads of state, which is talking about 2 million African community health workers in our goal to have universal access for all. Mr. Chair, therefore, I'm glad that the AFRO has come up with this framework, and we fully support it and look forward to working with all the countries in Africa to make universal health coverage a reality. Thank you.
Thank you, Zambia. Your emphasis on the issue that ability to pay is not the issue, but access to services is the issue. Cameroon, followed by Gambia.
Thank you, Mr. Chair. We tie our hands with all the members here present to congratulate the Regional Secretariat for this document, which is well written, which is legible and well understood. The relationship between universal health coverage and sustainable development goals, especially the health related, are well understood by us in Cameroon. We all know that Africa did not meet with the health-related MDG targets by the close of 2015, the reason why they were redirected to what we now call SDGs. With instruction from the head of state of the Republic of Cameroon, universal health coverage has become an emergency agenda in Cameroon. We've started assembling all the momentum to roll out universal health coverage. We began by advocacy and information sharing, and we have crossed over to review of the health infrastructure that are going to be responsible for universal health coverage. We've also identified the common pathologies that will be included in universal health coverage, and we are developing the protocols on how this pathology will be managed according to our health pyramid. However, strategy documents are being developed. We have opted for our approach, which is stepwise. By the end of this year, we're going to have a very big meeting that will look all to the nitty-gritties of rolling out universal health coverage in our country. We hope that we'll come out with something very solid before the close of this year. Thank you, Mr. Chair.
Thank you, Cameroon. Universal health coverage is now an emergency. I think that's a very strong stance.
Gambia.
Yes.
And then Namibia.
Right. I'll call upon now Gambia. Yes, Gambia and then Namibia.
Thank you, Mr. Chairman. We are cognizant that universal health coverage underpins the achievement of the health and related SDG targets. There have been significant achievements recorded for child health outcomes because of improved access to basic healthcare services across the country, and evidence shows that up to 85% of the population are within 5 kilometers of a primary health care and reproductive health facility, leading to similar successes. We are cognizant of the substantial improvements made in population health outcomes over the past 25 years. These improvements are reflected in better availability and utilization of services targeted at addressing the priority disease burdens marked by an increase in total health. Remarkable successes have been registered in the Gambia in the bid to meet the Millennium Development Goals target. Maternal and child health services are offered free of charge at public health facilities. The Gambia Demographic and Health Survey 2013 indicates that infant mortality rate has dropped to 34 per thousand against the MDG target of 42 per thousand, and under 5 mortality rate is reported at 54 per thousand live births against an MDG target of 67.5 per thousand. We reduced overall malaria parasite prevalence of 0.1%, and HIV prevalence rate has declined from 2.8% in 2006 to 1.9% in 2013. We acknowledge that the region is experiencing demographic, economic, social, security, and environmental changes that place unique demands on health and related service delivery systems. The Gambia has one of Africa's highest population density, 153 persons per square kilometer, and population rates at 3.3%, with an estimated 1.8 million inhabitants. Nearly 60% live in urban settings, implying a heavy demand on social services, including healthcare, in the urban centers. Furthermore, the government budgetary allocation rose to 10.5% in 2016, although still below the 15% Abuja Declaration target. Meanwhile, out-of-pocket expenditure constitutes 21.2% of the total health expenditure and continues to be a huge burden on households, impacting negatively on the livelihood. Finally, we endorse the regional committee to examine and adopt the actions as proposed. Thank you.
Thank you, Gambia, for supporting the paper. Namibia, followed by the DRC.
Thank you, Mr. Chair. One of the key phrases in the definition of universal health coverage is quality services, which is fundamental in the delivery of health services. It is important that we consider the governance mechanism through which we can achieve quality within healthcare systems. The basic approach to ensure quality of a service or a product is to set standard of performance, assess actual performance against the standard, and bring about corrective quality improvements. However, in many cases, Chair, ministries responsible for health are also responsible for policy making, service delivery, and regulation. We believe a clear separation of function is especially between service delivery and regulation, can serve as an excellent principle and approach towards achieving quality of health care. Therefore, we advocate that under the principle, policy, planning, and investment in the framework should strongly advocate for separation of functions as a principle. Alternatively, it can also be advocated under paragraph 20, country leadership and ownership, or paragraph 34 of the framework, quality of care. Mr. Chair, with specific reference to the framework's objectives, targets, and milestones, we are pleased to note, at least within our understanding, that these are encompassing the definition of universal health coverage, including indicators for accessibility, quality of service, and financial protection. That being the case, we assume, and the Secretariat may wish to confirm, that the proposed monitoring framework is a set of clear indicators that will provide a measure of quality, equity, and affordability. Mr. President, with these remarks and further clarifications, Namibia is happy to welcome the proposed regional framework for health systems development towards achieving UHC. Thank you.
Thank you, Namibia. Your emphasis on the distinction between service delivery and regulation, I think that is a pertinent observation. DRC, followed by Senegal.
Merci, Monsieur le Président, pour la parole. Les projets du cadre pour le développement du système de santé proposé par le secrétariat est à notre avis complet et de très bonne qualité. Et nous les félicitons pour cet important travail. Cependant, nous soulignons la nécessité d'intégrer une intervention en faveur du renforcement des capacités du personnel de santé et que l'accent soit aussi mis sur la qualité des services essentiels fournis aux communautés. Quant à notre pays, nous vous informons les efforts qui sont déployés pour la mise en œuvre des mécanismes en vue d'en assurer la couverture universelle. À titre d'exemple, les centres d'opération des urgences en cours d'être rendus opérationnels. Deuxièmement, le lancement du programme de financement basé sur les performances qui permettra la prise en charge des patients. De ce fait, la RDC soutient l'adoption de ces cadres. Je vous remercie.
Thank you very much, DRC, for supporting the paper. Senegal, followed by Burkina Faso.
Merci beaucoup, Monsieur le Président. Nous tenons tout d'abord à remercier le secrétariat pour avoir préparé et proposé ce document pour être amendé lors de cette session. C'est un document qui est très bien fait dans son ensemble et qui, en tenant compte des contributions, lorsqu'il est appliqué, permettra sans nul doute d'aider les pays à tendre vers la couverture sanitaire universelle et peut contribuer à l'atteindre des objectifs du développement durable. Ce cadre qui nous est présenté a le mérite d'avoir mis l'accent sur les postulats de base qui reposent sur les 6 piliers du système de santé. Lorsque ces 6 piliers sont réunis, il s'agira en fait de les renforcer pour essayer de faire répondre au système de santé à la demande des populations. Ce qui fait que parmi les 5 mesures et actions prioritaires présentées, qu'on peut résumer en 2 groupes, le premier groupe qui vise à réduire la charge de morbidité et le deuxième groupe qui permet de rendre facile l'accès aux soins par les dispositifs de prépaiement. Alors notre contribution à ce niveau, c'est que nous avons constaté qu'il y a un accès qui est extrêmement important, qui a été peut-être noyé dans le paragraphe 31. c'est l'accès en rapport avec la multisectorialité et la prise en charge des déterminants. Nous pensons que cela est extrêmement important, puisque lorsqu'on voit les mesures et actions prioritaires présentées, c'est des actions qui appartiennent au secteur de la santé. Mais on ne pourra pas aller à la couverture sanitaire universelle lorsque on ne sera pas en mesure de développer une collaboration avec d'autres secteurs qui, lorsqu'ils ne fonctionnent pas bien, leur mauvais fonctionnement entraîne une conséquence ou bien a un impact sur la santé des individus. Donc je pense qu'il faut ressortir, il faut un axe bien identifié qui va adresser la question de la multisectorialité et la prise en compte des déterminants. Monsieur le Président, voilà les quelques commentaires que nous inspire ce cadre. Nous vous remercions de nous avoir donné la parole. Merci.
I want to thank Senegal for emphasizing the issue of multi-sectoral approach. Burkina Faso, followed by Equatorial Guinea.
Merci, Monsieur le Président. Burkina Faso n'avait pas expressément demandé la parole, mais comme vous adorez le Burkina Faso, je ne vais pas me priver donc d'intervenir et de contribuer. Et je me joins aux autres pour féliciter le secrétariat pour le cadre pour le développement des systèmes de santé en vue d'assurer la couverture sanitaire universelle qui nous est proposée et pour lequel donc le Burkina Faso souscrit entièrement à l'ensemble des mesures qui ont été proposées pour construire ce dispositif de couverture sanitaire universelle. La contribution du Burkina Faso serait sans doute de reconnaître que le document est essentiellement bien développé pour tout ce qui concerne l'offre de services, l'offre de soins, et nous avons des difficultés avec l'aspect demande, l'aspect demande qui est capturé sur les points 28 et les points 35. Je ne sais pas ce qui s'est passé, mais sans doute le Bureau international du travail a été plus prompt que l'Organisation mondiale de la santé pour théoriser sur l'assurance maladie universelle. De sorte que dans nos pays, particulièrement au Burkina Faso, le leadership pour protéger les populations du risque de la maladie est porté par le ministère du Travail. Nous avons peut-être 500 000 personnes ou 1 million de personnes qui travaillent et qui ont un salaire, mais le Burkina Faso compte 20 millions de personnes. Le mandat du ministère de la Santé couvre 20 millions de personnes et c'est celui qui a un mandat sur 500 000 personnes qui doit développer la stratégie nationale pour protéger la population du risque maladie. Je ne sais pas qu'est-ce qui s'est passé au niveau du système des Nations Unies pour que ce leadership du Bureau international du travail dans la couverture santé soit répercuté dans les pays pour que le ministère du Travail ait la responsabilité de l'idée tout ce qui tourne autour de l'assurance maladie universelle. Donc ça, c'est un vrai problème où nous avons le mandat de développer la couverture sanitaire universelle. Le meilleur instrument pour amener tout le monde vers les services et les soins, c'est l'assurance maladie, et nous n'avons pas ce mandat dans le pays. Comment construire? Si vous avez une voiture et vous n'avez pas le carburant, comment vous allez avancer? Ça, c'est une problématique et nous devons réfléchir pour savoir comment ce leadership peut être inversé pour que le ministère de la Santé ait la pleine possession de tous les instruments pour amener le pays à la couverture sanitaire universelle. Je vous remercie.
Thank you, Burkina Faso. You did not want to talk, but you have raised a very important issue. where medical insurance is usually taken as a safety net and a social protection net, which is then put to public service, social welfare. But private medical insurance still lies more with the Ministry of Health. So we need to harmonize that. And it is true that we find it in governments. When you talk about National Health Insurance Scheme, some are saying no, it should be under the Ministry of Health. Others are saying no, it's a social safety net, it should be under public service. So I think it would be a good discussion here to just clarify that issue. And thank you for raising it after all, even though you didn't want to own up to talk. Nigeria, Equatorial Guinea followed by Nigeria.
Merci, Monsieur le Président. Je saisis de cette occasion pour féliciter avant tout à la République du Zimbabwe pour l'accueil chaleureux et l'excellente organisation de cette réunion à Victoria Falls. D'autre part, nous félicitons le secrétariat de l'OMS pour l'excellente préparation et par la qualité du document d'orientation axé sur le développement du système de santé en vue d'assurer la couverture sanitaire universelle dans la région africaine. Notre pays a exprimé depuis un certain temps la volonté politique de garantir la couverture sanitaire universelle à la population. Et c'est à ce sujet, malgré les très bas taux de la population couverte par l'assurance maladie en Guinée équatoriale, presque moins de 20%, le gouvernement a adopté certaines dispositions l'année dernière qui garantissent les soins gratuits pour les femmes enceintes et les enfants de moins de 5 ans. Les documents et tableaux proposés sont assez explicites, complets, mais généralisés, à notre avis. Il serait souhaitable de notre part que l'OMS assiste techniquement aux pays de la sous-région pour faire une analyse de la situation cas par cas, pays par pays, afin d'adapter ces tableaux au contexte particulier de chaque pays et ainsi établir une feuille de route à suivre pour atteindre la couverture sanitaire universelle dans les pays de la région africaine dans le contexte des ODD. Si je dois citer ces besoins dans le contexte actuel de notre pays, la Guinée équatoriale, notre pays a investi dernièrement d'énormes quantités d'argent dans la construction de grands hôpitaux avec des technologies de pointe, alors que les soins primaires de santé et le personnel qualifié en font défaut dans certaines régions du pays et l'assurance maladie, comme je l'ai dit avant, est à un taux de moins de 20% de la population. La conséquence immédiate de ce déséquilibre est que l'État doit continuer à investir pour les populations démunies sous forme d'aides sociaux et doit toujours financer les évacuations vers l'étranger des malades qui ont laissé leur maladie évoluer à un stade très avancé par manque de moyens. Conscient de cette situation que nous devrons redresser dans un contexte de crise économique causée par la chute du prix du pétrole, le gouvernement est en train d'entreprendre des réformes socio et sanitaires qui s'avèrent lentes à appliquer par le coût élevé que cela suppose pour notre finance publique. C'est la raison pour laquelle nous demandons l'assistance technique de l'OMS afin de nous appuyer pour travailler sur réorganiser notre système de santé. Il est évident qu'actuellement, nous sommes en train de travailler sur un nouveau PNDS, Plan national de développement sanitaire, et en plus avec l'appui technique de l'OMS. Et cela va nous permettre d'identifier la situation réelle actuelle et l'orienter surtout dans les soins primaires de santé. Finalement, nous nous alignons sur la nouvelle orientation de l'OMS qui est proposée sur ce document et dont nous soutenons entièrement. Je vous remercie.
Thank you very much, Equatorial Guinea, for lending your support to this document. Nigeria, followed by Ethiopia.
Thank you, Mr. Chair. In Nigeria's review of the framework, we noted the need to mention shortages and unaffordability of medicines, vaccines, and medical products as one of the challenges for health system development towards universal health coverage in the context of the SDGs. Nigeria proposes the inclusion of these under issues and challenges on page 2 of the framework document. Secondly, we wish to propose changes in the goal of the regional framework as articulated in paragraph 17 as to guide member states' efforts towards realigning their health systems in a manner that facilitates the attainment of universal health coverage and their aspirations for health in sustainable development, instead of stating movement towards universal health coverage. Thirdly, Nigeria wishes to propose under objectives in paragraph 18.1 the replacement of comprehensive menu with essential package of services, more so when this term is used elsewhere in the document, as in targets A, paragraph 19. Fourthly, Nigeria observes the absence of the inclusion of quality of care among the guiding principles. This is important as quality of care forms one of the principles of universal health coverage. Similarly, quality of care should be added to the priority interventions and actions. Prior to adoption of the SDGs by member states of the UN, Nigeria had taken a bold and landmark step through the Presidential Declaration on Universal Health Coverage in the year 2014. Recognizing the critical importance of achieving UHC through a resilient health system, the Federal Ministry of Health has articulated a holistic strategy to revitalize our health system through legislative and a conducive legislative environment. The National Health Act was enacted in 2014, and this provides for a sustainable funding stream for healthcare service delivery in Nigeria. Strategies have been laid out to define modalities for ensuring that the implementation of a basic package of health services will happen in a revitalized and resilient system. To further ensure a strategic focus, a new National Health Policy 2016 has been articulated and adopted. This policy was developed following an elaborate and detailed serial consultative engagement with all stakeholders from within and outside the health sector. This policy is aimed at addressing and improving systems performance, which had hitherto eluded the country despite all efforts at developing a holistic approach. Emanating from policy provisions in the National Strategic Health Development Plan 1, with the aim of addressing an essential package of health services with a resilient health system, the National Strategic Health Development Plan 2 is currently being developed to ensure the provisions of a robust essential package of health services in addition to the basic minimum package that will be funded from the 1% Consolidated Revenue Fund as provided for in the National Health Act. In order to ensure sustainable financial risk protection for all, efforts are ongoing to review and revise the National Health Insurance Act. This review will ensure a mandatory health insurance scheme for all Nigerians, including the vulnerable groups. The legislative arm of government, as major stakeholders, has been well situated in the UHC space through the legislative network for universal health coverage. The main objective is to impact knowledge to better perform their legislative role towards a positive impact on UHC outcomes that will ensure that Nigeria remains on track towards UHC and SDGs. Recognizing the need for extensive funding requirements to achieve UHC, a network of national universal health coverage champions and advocates from the health sector was inaugurated in February this year towards achieving sustainable financing for health. These eminent Nigerians have been tasked with advocating for increased funding for health from the private sector and donor agencies. Central to the above-mentioned strategies and initiatives for a resilient health system for UHC and the SDGs is the PHC, the Primary Healthcare Revitalization Initiative of the current administration, that will ensure the functionality of at least one primary healthcare facility in every political ward in the country in a phased manner, such that over a 3-year period, a total of about 10,000 primary healthcare centers will be functional in terms of adequate infrastructure, human resource, capacities, and supplies to provide a basic minimum package of health services across all political wards in the country. In articulating these initiatives to ensure a resilient system for healthcare delivery in Nigeria, we have experienced several challenges which has not deterred us, but rather has strengthened our resolve to forge ahead in our sincere desire to keep Nigeria on track towards UHC. We observe that prices of medicines, vaccines, and health commodities are on the increase. Also, the population in need is on the increase, or the fiscal space is severely constrained. How do we address this? Topmost is strategic stakeholder engagement. Lessons learned include recognizing that different stakeholders wield different degrees of power at different levels, and as such require different strategies for engagement. We also recognize the need to further engage more strategically with the private sector health service providers, since they provide over 45% of healthcare services in Nigeria. Most importantly, we recognize the need to create mentor states and suitable platforms that will ensure ownership and sustainability. WHO will be required, however, to give close guidance and technical support to countries towards achieving the actions outlined in the document. Nigeria therefore recommends the actions proposed in this framework document and supports its adoption. Thank you.
Thank you, Honorable Delegate from Nigeria, especially for emphasizing the issue of the goals that you need changed. Maybe you can submit the new text to the Secretariat, what you are proposing as changes to the Secretariat. And your emphasis on quality of care is important. But you have also created universal health coverage champions. I think this is something quite interesting. Ethiopia, you have the floor, followed by Kenya.
Thank you, Mr. Chairman. Ethiopia welcomes the framework for the implementation of the global strategy on human resource for health in the African region. Since we launched National HRH strategic plan, which is for 2060-20 to 2025, we are striving to ensure equitable distribution of health workforce with appropriate skill mix and quality throughout the country. We believe in that the aforementioned activities accelerate progress toward the attainment of universal health coverage and the Sustainable Development Goals. The government of Ethiopia's strategy to retain the health workforce in the public health sector in the last decade has brought about a significant difference. We are also making great effort to keep record of health workforce through implementation of human resource information system that will inform the development, implementation, monitoring, impact assessment, and continuous updating of health workforce at national level. Mr. Chairman, Ethiopia has initiated expansion of health education institutions by increasing the number of medical schools, among others, from 3 to 33, and postgraduate programs, including specialty training, from 8 to 96 in 10 years period, which is to have adequate and good skill mix of health workforce in support of universal health coverage. Cognizant of the few specialists in the referral and comprehensive specialized hospitals, Minister of Health has taken the initiative this year to address a critical shortage of clinical specialists in the country through implementing centralized managed national residency matching program. The initiative has introduced with primary objectives of improving quality of medical education, healthcare delivery, and use it as motivation and retention mechanism of young general medical doctors. The plan is to increase yearly enrollment capacity of medical specialty training universities from 500 residents to 1,000 residents in 22 medical specialty training disciplines. We have also given special emphasis to field epidemiology master's program to intensify public health emergency interventions and subspecialty level nursing training to improve quality of care. To strengthen the primary health care, we are also providing refresher training for 32,000 health extension workers or community health workers, and there is a plan to upgrade the educational level of them in order to realize universal health coverage. We are also committed to World Health Organizations and Regional Committee for Africa resolutions and achieved significant changes on strengthening health workforce education, requirement, deployment, and retention. Thus, we request the Secretariat to increase support to strengthen availability, accessibility, acceptability, and quality of health workforce to ensure healthy lives for all at all ages. I thank you.
Thank you, Ethiopia, for really supporting this framework. Kenya, followed by Liberia. We're nearly there.
Thank you, Mr. Chair. Like many other countries in sub-Saharan Africa, Kenya faces a critical challenge of creating the foundations of long-term inclusive growth. we believe as a country, our health agenda is clearly defined by health policies, legislation, and national blueprints for sustainable development. To be able to achieve sustainable goals, Kenya remains committed to implementing health systems reforms towards universal health coverage. And these reforms target 4 main areas, which includes the modernizing the public health infrastructure to improve equity in availability and coverage and access to health care. 2, the innovations in improving healthcare provision, especially for populations in the informal settlements and other underserved areas. 3, the rapid expansion of health training institutions and increased domestic budget in support, all in order to compensate the user fees that were abolished in primary health care levels and for maternity services. Chairperson, in addition to these focus areas, Kenya has initiated other key interventions to improve financial risk protection for persons utilizing healthcare services. And this includes health insurance for the poor, the elderly, and the persons living with severe disabilities. As a government, we are gradually incorporating a shift from the traditional funding to service delivery inputs to output-based payments. In terms of the next steps for UHC in Kenya, Kenya is scheduled to launch the very first health financing strategy in the next coming 1 week, which is going to actualize these health reforms. Key highlights in this strategy includes addressing the health inefficiencies, advocating for increased budgetary allocations, introduction of mandatory health insurance, introduction of health insurance subsidies for the poor and the vulnerable, as well as strengthening the public-private collaboration, harmonization, and alignment of external resources to improve efficiency and effectiveness. Chairperson, Kenya is convinced that with strong and effective partnership through the private sector, the development partners, achieving universal health coverage and sustainable development goals by 2030 is possible. The Chairman, Kenya has developed and launched an SDG platform through the public-private partnership to strengthen the primary health care to enhance service availability and coverage. In view of the foregoing, Kenya strongly recommends the adoption of the actions proposed in this framework towards realization of the Sustainable Development Goals. I thank you.
Thanks, Kenya, for that robust contribution. And the issue of mandatory health insurance is an interesting one. And I think it will need to be discussed. Mandatory to who? Everybody who works or everybody who lives? So it will be interesting to define that. Liberia, followed by Ghana.
Thank you, Mr. President. Again, Liberia wish to express gratitude to the Secretariat for putting forth this agenda item. Liberia wish to share with you her plan of action to achieving UHC. To do so, let's begin with what we think UHC is and what it is not. UHC will make progress towards the other health-related targets and towards the other SDGs. Good health allows children to learn and adults to earn, helps people escape from poverty, and provides the basis for long-term economic development. Health services for all individuals and communities without suffering from financial hardship. On the contrary, UHC does not mean free coverage for all possible health interventions regardless of cost, no country can provide all services on a sustainable basis. UHC is not just about health financing. It encompasses all components of health system, health service delivery system, the health workforce, etc. We feel that moving towards UHC requires strengthening health systems, ensure robust financing structure, pooling funds from compulsory funding sources such as mandatory insurance contribution, which could help spread the financial risk of illness across the general population. Investment in the primary healthcare system, workforce, quality care with patient center, good governance, supply chain, health infrastructure, etc. We feel that a strong primary care is the lifeblood of every health system, and no country can achieve UHC without it. Health financing reforms are crucial. Therefore, it is imperative that we all work towards UHC, and Liberia supports the adoption of the strategy. Thank you.
Thank you, Liberia, for that support. Ghana, followed by South Africa. Yes, Ghana, followed by South Africa.
Thank you, Chair. I commend again the Secretariat for the report of the African Regional Framework for the Implementation of the Global Strategy on Universal Healthcare. We wish to make the following interventions regarding the outcomes in UHC. Accessibility of essential health service. Through the community-based health planning and service program, we try to provide essential services to the underserved areas through increased training of community health nurses, supported by trained community health workers, taking advantage of ICT to improve data collection, disease surveillance, and provision of maternal and child health services at the community level. The CHIPs are supported by sub-district and district health systems. Ghana is also providing National Health Insurance Scheme to provide financial risk protection for the poor and the vulnerable. The government of Ghana is in the process of restructuring the National Health Insurance System, which was introduced as far back as in 2003. Ghana's health system, insurance system, is mandatory as well to all citizens and even foreigners living in our country. We have a scheme designed such that those who are not working, the very poor, vulnerable people, are all covered. So we have identified some groups of people we call the indigents. We subscribe insurance free for pregnant women. Postnatal services and deliveries are covered for free. Children under the ages of 18 years are covered for free. People who qualify and have been identified as very poor, and we use our social protection system to support their livelihood, they also qualify for free. And then we have pensioners also qualifying to subscribe health insurance for free. So invariably, we are covering everybody. Those of us who are working are rather paying for subscription. And we have a levy that supports the funding of the schemes. We are restructuring. We are not very close to getting very efficient yet, but it looks like we are very far advanced when it comes to using health insurance to grant access for health to almost everybody in our country. I mentioned CHIP compounds, and as we speak, we have over 2,000 community health planning and services compounds in our country, and these are being supported by sub-district facilities that are a little bit more advanced and our district hospitals. We also undertaking health prevention, promotion, and rehabilitation of the people across the country. For health infrastructure, there is a policy to provide basic health services through the CHIPS concepts. Plans are also on the way to provide functional district hospitals and health centers to support services at the lower levels of care. And Mr. Chair, it will be interesting to hear that the current party ruling the country at the moment in their manifesto introduced several, will I say, phrases in their campaign. And one of them was one district, one hospital. And we are following that concept seriously to provide general care facilities, to a certain level of standard for all districts in our country. We now have 10 regions in our country, and all of them have got regional hospitals. These are close to very high tertiary institutions. We have 5 teaching hospitals in the country, located across the country in some of the regions. No 2 teaching hospitals are found in one region, and they do the tertiary care for us in the country. Our provision of universal health care is a right of the people, and an essential part of the SDGs is human rights. The right to health is in fact enshrined in the Constitution of Ghana. We therefore wish to emphasize the need that all necessary action is taken to ensure universal health coverage. For us, that is part of our prime legislation, and we are living towards that. So universal health coverage has come only to strengthen our dreams to move us further closer to that realization. For medicines, we are working to try to bring down cost of medicines such that all of us in the country can afford to procure or buy where health insurance doesn't cover. Presently, we are working on our supply chain master plan to try to see how efficiently we can reform that area to give us cheaper medications. We're working closely with local manufacturers now. Last 3 months or so, the Finance Ministry announced a ban on importation of locally manufactured medicines, said that we can have our drugs cheaply. Earlier on, around March, there was a pronouncement of reducing some taxes from even those medicines that have not been imported in the country. And government is consciously working with private sector to support them actually do more manufacturing of medicines that are found on the essential medicines list. For the workforce issues, I think I'll wait until we come to the framework where we shall have a lot of room to do human resource issues that we have, all towards universal health coverage. So, Mr. Chair, Ghana will continue to support the framework for universal health coverage, and I think we will have to urge my colleagues to take time to visit Ghana to see where we are and what lessons can be taken away from Ghana. I think we are a little bit advanced when it comes to universal health coverage. Now, manifesto in our constitution, practical on the ground, covering accessibility, affordability, and whatever that you have. So it looks like if any country in Africa will achieve universal health care on assessment, I want to say that Ghana may have to take the lead, and there's a lot to learn from Ghana. Thank you, Mr. Chair.
Thank you, Ghana. A very eloquent presentation there. And I think you're one of the first countries to introduce national health insurance schemes on the continent, and you are also leading in other areas. So thank you. I hope that somebody talks about universal health coverage in the context of traditional medicine, because 80% of our people do consult those people.
Mr. Chair, we have a traditional alternative medicines department in the Ministry of Health. And we have a council. And we have a research center that goes into plant medicine. And we have now licensed, and our Food and Drugs Agency accredits local medicines, and they are found in pharmaceutical shops that are doing well in our country. We have about 18 hospitals that have traditional medicine outlets within the hospitals. And then we have a university that is training traditional medicine practitioners as doctors to man these facilities. So we have allowed our regulation to actually embrace the use of traditional medicines in our hospitals, in our pharmaceuticals, and wherever you find them. Thank you, Mr. Chair.
Thank you. I really didn't mean to provoke this, but I call upon South Africa, followed by Zimbabwe.
Thank you, Chairperson. South Africa indeed welcomes the framework for health system development for universal health coverage in the context of sustainable development goals in the African region, as presented by the Secretariat. Chairperson, we will take the offer from Ghana. We will take the offer, a colleague who will visit, and I also want to take this opportunity to congratulate Ghana for being one of the first country, if not the first country, I think the first, yes, on the whole continent to implement universal health coverage. And I think it's important, Chairperson, that we learn from each other. And so we'll definitely come, expect us. Thank you. Now, Chairperson, in our case in South Africa, universal health coverage, which we call NHI, or National Health Insurance, is not only going to be a major health transformation plan. It is first and foremost going to be a form of radical economic transformation of our country, as well as a major social transformation of society towards a more equitable society. I believe, Chairperson, if in South Africa we are able to implement universal health coverage, it will be a major test case in the whole continent as to whether there can ever be equity between the rich and the poor in healthcare provisioning within our lifetime. It's really going to be a test of whether, when Dr. Margaret Chan, the former Director General of WHO, said that universal health coverage is an equalizer between the rich and the poor, whether this is possible in this harsh world of reality, or whether it exists only in our dream world, as some forces within my country and around the world, as you can see what's happening in the United States, have all alleged. Let me explain all these things, Chairperson, what I actually mean. In my country, we are running two healthcare systems. We are running two healthcare systems parallel to each other in South Africa. One healthcare system is in Europe, and the other is here on the African continent. The one that is in Europe has been re-Christian private healthcare, and the one that is on our continent is called public healthcare. Now, these two systems are not in our constitution, actually. They do not exist in our constitution. They just developed on their own, which, Chairperson, demonstrates the point that society will evolve in its own destructive direction if states and government do not intervene and direct events. And that's why it's important that states and government and world bodies must intervene on this issue of universal health coverage. Otherwise, what will result will be what I see in my country. Now, Chairperson, as you know, the World Health Organization has worked out that if countries spend just 5% of their gross domestic product on health, they will have very good health outcomes. And I want you to know that 5% refers to the total gross domestic product of the country, not to the budget of that country. It's the gross domestic product, the wealth of that country. Which means when we implement universal health coverage, we must forget about budgets and move over to the gross domestic product. What is the total wealth of the country? What is the percentage of the total wealth of the country that goes to health care? And who does it go to? Which individuals benefit? And to what extent are others left out? That's what universal health coverage is all about. Now, in my country, we have far exceeded this 5%. We are already at 8.5%. The same as Europe, whose countries average 9%. I've learned, Chairperson, that countries in Europe spend roughly 9% of their GDP on health. We are on 8.5%, which means we are within the same bracket. Now, if you don't understand the significance of these figures, let me refer you to BRICS countries. Within BRICS, Russia is still at 5.4%, China is still at 4.6%, India is still at 4.2%. My country is at 8.5%, but I'm sure everybody knows the health outcomes in all these countries, in Europe, in Russia, in China, in India, are far, far better than the outcomes in South Africa. So as I say this, I think your question, if you were to question me, will be, where is this money going to? And Chairperson, the answer is not only bad, but it's quite ugly. It's ugly because my answer to you will be 4.4% of this 8.5 goes to only 16% of the population. And the remaining 4.1% has to be shared by 84% of the population. Now, the story I was trying to narrate here to this House is that in South Africa, we believe there is enough money to implement universal health coverage very readily and leave nobody behind. But unfortunately, the money is captured by a few of us. I say us because I am part of this 16% of the population. I have to be honest. Yes, I am part of that. So it's a few of us who have captured this money. Chairperson, page 2 on paragraph 9 of this document says, the relative improvements in availability and coverage of health services are not uniform across and within member states. And as you can see, the figures I've quoted actually points to that. I suspected they were meaning South Africa when they were talking about this. It's not uniform. And I've come to believe, Chairperson, that in 1978, when the World Health Organization, at the primary health conference in Alma Ata, which was held in Alma Ata, stated that the existing gross inequalities in health status of populations between developed and developing countries, as well as within nations themselves, is politically, economically, and socially unacceptable, and is of common concern to all. I suspect these words were directed at South Africa, though I know that many countries can be described in a similar vein, but my country is a very stark, ugly example of what can happen with inequalities. Now the question is, when I say us and I say I'm part of this, who are these people who have captured 16%, who constitute 16% of the population who have got all this money? It is teachers, doctors, nurses, magistrates, judges, politicians in parliament, police, the army, accountants, engineers, and all the captains of industry, meaning people who are running the state, who have got political influence, who have got economic influence, who have got the power and the know-how. And who constitute the 84%? It is the rest of the population, the masses, the overwhelming majority, those who are vulnerable. So we want to change this state of affairs. And unlike any other country on the continent, our universal health coverage will depend on whether we are able to successfully stage a socio-economic revolution to recapture the resources and use them for all our citizens, irrespective of their socio-economic status. That is what universal health coverage is going to be all about in my country. And as I'm listening to Cameroon, Chairperson, we need a Cameroonian type of emergency to achieve this type of coup that I'm mentioning here. because he talked about an emergency. I think we need something like that. And we'll go and see how the emergency is run. The second area, Chairperson, I want to deal with in this case is that the success of universal health coverage globally, but most specifically in Africa, will depend on whether we're able to extricate ourselves from the uncompromising and debilitating clutches of a curative health care to a primary health care where prevention of diseases, promotion of health, and entering the healthcare system at the clinic level rather than at the hospital level is the norm of the day, which will also include a very clear cohort of primary health care workers. This move toward primary health care is definitely going to constitute a coup against commercialization and commodification of health, because truly speaking, Chairperson, at the present moment, except in a few countries like Cuba, our healthcare systems are largely expensive, non-result yielding curative systems, and we need to change away from that. We believe this revolution to universal health coverage will liberate not only the poor, Chairperson, even the rich, and please allow me to demonstrate one example. We have got a new drug to cure breast cancer called trastuzumab or Herceptin. Maybe let me use the simpler word before I break my tongue. Herceptin, which is very good for certain types of breast cancers. Now, breast cancer is #1 killer of women, which constitute the vulnerable group in our definition here. But one dose of Herceptin is $1,846 American dollars. And one treatment cost is 17 doses. Meaning we are expecting a woman to pay $1,846 American dollars times 17. That is $31,000. Now tell me which woman of what socio-economic group could afford this. It simply means if you have got breast cancer, you are unfortunately going into catastrophic healthcare expenditure, which simply means in simple language, poverty. So, Chairperson, in conclusion, I want to say this. Universal health coverage is not a program brought about by technicians and experts. It's a political program. I want to state that. It's a political program which is driven by political will. And the question is, do we have the political will to drive this program? I would like to refer you to a document here, Chairperson, and I would like to politely ask that the Secretariat must incorporate this document within which I'm going to give you. They must incorporate this document because to me it expresses why I'm saying this is a political will. Nelson Mandela, as you know, in 2007 established a group of elders, independent elders, who have got collective experience and influence for peace, justice, and human rights around the world. For those of you who never came across this group, which celebrated their 10th anniversary in July, on the 18th of July, on Nelson Mandela's birthday in Cape Town, the group is chaired by Kofi Annan, the former Secretary General of United Nations. There's Gro Harlem Brundtland, who was once the Director General, as you know, Marty Atisari, Ella Bat, Lakhdar Brahimi, Fernando Henrique Cardoso, Jimmy Carter, Hina Gilani, Graça Machel, Mary Robinson, Ernesto Zedillo, and Bishop Tutu, Archbishop Desmond Tutu as an honorary elder. While Madiba said they must help the world in peace, justice, and human rights, Chairperson, they've produced this document, which is called Universal Health Coverage Position Paper. They said they want to contribute, especially by influencing heads of state, because this is a political program. And they say across the world, hundreds of millions of people are currently denied life-saving health services or are plunged into poverty because they are forced to pay unaffordable fees for their care. This burden is particularly felt by women, children, adolescents, who often have high needs for health care but least access to financial resources. And they go on to say, in some instances, women and babies are even being imprisoned in health units because they cannot afford to pay for their medical bills. Now, Chairperson, this document, in conclusion, it makes 4 proposals, and I'm not going to mention here, obviously, because there's no time. But as I said, I'm appealing that the Secretariat take it, but I cannot leave the platform, Chairperson, without reading the last proposal, which I think is going to be a big debate around the world, even among ourselves on the African continent, about how to conduct universal health coverage. They are making 4 proposals, and the 4th one is public financing is the key to universal health coverage. Because they say across the world, countries are realizing that a free market in healthcare, with people buying and selling medical services like other commodities, will never be able to achieve universal health coverage. In such a system, only the rich will receive adequate coverage, and the poor and vulnerable will be excluded. This not only impacts adversely on health and welfare of the poor, they say it also poses a threat to global health security, as a recent Lancet review on Ebola outbreak has demonstrated. They go on to say, governments are recognizing that to reach universal health coverage, it's a fundamental responsibility of the state to organize and oversee the health financing system. Public financing is therefore increasingly being recognized as the key to achieving universal health coverage. This does not mean that governments have to provide all health services themselves. There are many good examples of countries achieving universal health coverage by using public funding to deliver services throughout both public and private health care. And they quote even countries that are doing that. And they end up by saying, Chairperson, however, they are aware that many countries are lagging behind. And they say the reason of lagging behind appear to be lack of political will in these countries to sustain this political commitment of universal health coverage. So, Chairperson, I humbly want to submit this document because I think this is what we should be, if we are not yet, what this document describes. Thank you very much.
Thank you, Dr. Motsoledi, for that very passionate critique of universal health coverage. Public financing, number 1. And I think, to me, that's the ultimate demonstration of political will. And you are talking about a document that should be incorporated by the Secretariat. I hope you can take that on board. It's an expensive system that we are running now because we are not using the primary healthcare approach. And you've summarized it extremely, extremely well. We emphasize too much on the curative services because we've failed on the primary healthcare approach. But South Africa has got European health system and African health systems. We need to address that error. I mean, with a revolution, like you rightly say. And I think that you really have summarized these things very well. I'll call upon Zimbabwe, followed finally by the United Republic of Tanzania.
Thank you, Chair. Zimbabwe takes the floor to contribute to the debate on agenda item 13, which deals with health systems development towards universal health coverage in the context of SDGs. We thank the Secretariat for working on this proposed framework. Of particular significance is that the framework tries to strategically tap on the other SDG areas as critical enablers in developing our health systems towards universal health coverage and achieving SDG 3. The framework really brings together in a logical way the many approaches developed over time to address health issues. It places in a much clearer way what our populations desire from us in terms of outcomes and impact while it pushes us as policymakers and service providers from focusing and concentrating on inputs and processes and outputs, where we seem to get stuck quite frequently. Zimbabwe is therefore in support of adoption of the framework, taking into consideration the input, particularly from Zambia, on attention to surgical services, as well as other input by previous speakers. Thank you, Chair.
That summary, United Republic of Tanzania.
Thank you, Mr. Chairman. The United Republic of Tanzania welcomes the framework for health systems development towards universal health coverage in the context of Sustainable Development Goals in the African region. This framework gives guidance to countries on how to strengthen their health systems to ensure the achievement of universal health coverage, thereby contributing to the Sustainable Development Goals. Tanzania has embarked on implementation of the Sustainable Development Goals, building on the achievements and lessons learned from the Millennium Development Goals. Remarkable progress has been made in reducing under-5 mortality as well as stunting. Maternal mortality rate reduction remains a challenge with no progress, and unmet needs are very high. This calls for acceleration of efforts to end preventable maternal deaths and achieve universal reproductive health. Mr. Chairperson, we have also developed the Quality Improvement Framework and a Quality Improvement Strategic Plan that spanned 2013 to 2018, with guidelines, tools, and training for the improvement of quality service delivery. This approach aims at addressing gaps and rectifying them so as to build trust and confidence of the communities extracting services from them. Chairperson, we note the significant burden of non-communicable diseases with associated mortality in developing countries. Also, the inclusion of non-communicable diseases in this Sustainable Development Goals is an important milestone. Now, interventions and activities addressing non-communicable diseases, prevention and control should be adequately resourced and the services for non-communicable diseases scaled up at the primary health care level. Mr. Chairperson, towards realization of our vision towards universal health coverage, a healthcare financing strategy has been developed and a health insurance bill for a single national health insurance will be proposed to the Parliament come September 2017. We appreciate the World Health Organization's support in the development of our National Health Sector Strategic Plan number 4 that spans 2016 to 2020. And in conclusion, Mr. Chairman, Tanzania proposes adoption of the regional framework with its proposed interventions and actions. Very grateful to you.
Thank you, United Republic of Tanzania. I think this was really a fruitful discussion. And after this, a lot of other things will be added in, I'm sure. Primary health care as emphasis to as central. And also the district health system. If we can strengthen the district health system and all its peripheries, then we go a long, long way. And also looking at emergency services. Emergency services, we can, this come in and it's an emergency service. We must look at that. And essential surgical services. No, these are things that we need to look at. But now, let me go back to the Secretariat, Dr. Volvo, Dr. Dovlo. If you could give us your response, thank you.
Thank you, Mr. Chairman. And again, on behalf of the Secretariat and the team working on this, to express our appreciation for the very fruitful comments that we have received, the edits that have been proposed, and also the examples from around the region that have been expressed. And we hope to continue to work to look at this as we provide knowledge and evidence to back up the actions that we shall take in this framework. We have
proposed ways of taking this forward, and we are glad to see that our member states are in general agreement with us around how we go forward with this. I want to mention in particular critically efforts in countries linking this to our national health planning cycles, linking this also to learning and knowledge management processes that would help us take this forward in a structured and evidence-based way. And again, we want to thank you for all those contributions. There are a number of issues raised that we need to consider and take forward as we move towards universal health coverage. The factor around the influence that intersectoral action has on health, the issues of the leadership mandate and where it should rest when we work towards universal health coverage, the fact that this, as part of the SDGs, should aim at transforming our societies, and the passionately expressed point around the fact that these efforts should be part of a change that would lead the region towards better efforts. We take on board the advice around how we quantify the investment that should be made on health. We have already started moving away from utilizing budget proportions to the per capita expenditure on health as a measure, and we take on board the angle that takes the total GDP proportion on health as drivers of investment in health, but also to do this with the lens of equity firmly applied to this. We have taken on board the lesson around the role, the leadership role that public financing has to take, even if it's in concert with the private sector, and also the expressions made around the role and leadership that governments have to play, particularly with insurance, with ensuring that out-of-pocket and other barriers to service for the vulnerable are mitigated. We agree wholeheartedly that the need for UHC is an emergency, and that we should make every effort possible to make sure that this transforms our social life and the inequalities in our societies. But also, as we mentioned during the lunchtime seminar, that there is also a heavy economic burden that not having UHC places on us. And we hope we can work with you both through the technical actions that we are taking, but also the political will and other actions that we have requested. And we hope you will find your leadership helping us to take this forward together. I would like to thank the Regional Committee for their comments and suggestions. Thank you, sir.
Thank you, Doc. Can I ask Dr. Joseph Kabore to say a few words, representing the Regional Director?
Merci, Monsieur le Président. Juste quelques mots. Le premier pour dire que le side event que nous avons organisé, le document introduit par Dr. Dovlo ont suscité des interventions très passionnées, très importantes, et qui ont mis l'accent sur le partage d'expériences. Et je pense que cela est extrêmement important, le pays étant à des niveaux de mise en œuvre de la couverture sanitaire universelle différents. Il est donc extrêmement important que ces expériences qui ont été partagées cet après-midi puissent être capitalisées, et surtout que l'appui au pays pour la mise en œuvre pratique de ces expériences-là soit poursuivi. Je pense que nous prenons vraiment compte et acte de ces propositions et que le secrétariat restera en contact pour que les opportunités soient offertes et apporter l'appui nécessaire aux États membres pour que nous fassions vraiment une avancée très notable dans la mise en œuvre de la couverture universelle en santé. Merci.
Thank you, Dr. Kabore. Well, distinguished delegates, is the Regional Committee ready to adopt the actions proposed in document AFR/67 2016/10 on a framework for health systems development for universal health coverage in the context of the Sustainable Development Goals in the Africa region, in line with the comments made. Oh, it is so decided. As usual, I will now pass the floor to Ms. Elise Jobert to make a statement on behalf of the Union for International Cancer Control.
Honorable Chairperson, Your Excellencies, and all other delegates, I thank you for the opportunity to deliver this statement on behalf of the Union for International Cancer Control, a membership organization representing 159 cancer organizations across the African region. We welcome the African Regional Offices Framework for the development to achieve universal health coverage, the aspiration of reaching the 80% targets by 2030, and the long-term commitment to health system strengthening, which this represents. We applaud recognition of the importance of integrating services for non-communicable diseases, and we wish to emphasize the critical role of palliative care in this context. Cancer is now the second leading cause of death annually, with 8.8 million deaths worldwide, and it should not be forgotten as one of the leading NCDs in Africa, accounting for over 455,000 deaths annually already in 2012. And we know that the burden is set to rise in this region rapidly. We wish to underscore the current enormous financial and social costs placed on families, with costs for early detection, diagnosis and treatment, and largely an out-of-pocket expense. We applaud the robust scope of the framework and its alignment with the recommendations in the Cancer Resolution World Health Assembly of 2017 and the associated cost-effective interventions for the early detection and treatment of cancer in Appendix 3 of the Global Action Plan on NCDs reviewed by the World Health Assembly in 2017. We emphasize the critical role of data for effective public health policy development and the role of population-based cancer registries in this regard. We welcome the attention to services at all healthcare levels and the emphasis on addressing the health workforce gap, as these are critical to early detection, the referral for diagnosis and the treatment of cancer, as well as the management and in the community of people living with cancer and other NCDs. We also welcome the underscoring of equity in access throughout, and we wish to take the opportunity to underscore the unique and pressing opportunity to significantly improve survival of children in cancer in Africa by the inclusion in the universal health coverage. And delegates, please do not forget that it was the enormous projected cost of inaction on NCDs which led to the heads of states' commitment to act at a high-level meeting in 2011. We urge that you recognize the actions in the Cancer Resolution as an investment in your national response to cancer in the face of the growing burden, and as an imperative for universal health coverage, which will show returns in health and economic terms by 2030. And lastly, the UICC would like to commend the members of the African region for the work thus far and stands ready to support countries to reduce the burden of cancer through our effective health coverage.
Thank you, Ms. Jobert, for your statement. I will now pass the floor to Ms. Genolet to make a statement on behalf of the International Federation of Pharmaceutical Manufacturers Association.
Thank you, Mr. Chair. Honorable Chair, distinguished delegate, thank you for the opportunity to contribute to this important discussion today. Today's meeting and the organization in June of the first Africa Health Forum on Universal Health Coverage emphasize the wide consensus of countries on the important enabling role of UHC in achieving health for all. IFPMA commends the integration of UHC as a goal in the national health strategies of African countries and the rapid increase in total health expenditure in Africa, which we have witnessed over the last 2 decades. Health plays a central role in enabling sustainable development, and investing in health goes hand in hand with economic growth and prosperity. As WHO's own research shows, much of the increase in health spending, however, has been due to an increase in out-of-pocket expenditure by household and development assistance. As Dr. Tedros Adhanom Ghebreyesus, WHO Director General, recently pointed out, UHC is more a political than an economic challenge, highlighting the need for further commitment from national governments to increase their spending. At the same time, IFPMA believes that structured, collaborative action on universal health coverage will help meet the shared goals of expanding patient access to medicines through innovative solutions and achieving long-term sustainability of the health sector. The pharmaceutical industry is an important partner, especially in regards to investing in medicines and vaccines development and pursuing innovative approaches to expand access. In addition, working in novel partnerships with NGOs, government, and private sector entities, the industry is supporting UHC through providing expertise in ensuring the quality and integrity of the supply chain, training healthcare workers, and filling gaps in underserved areas. These all support capabilities which are becoming increasingly essential as the burden of non-communicable diseases rises in Africa, populations age, and more countries transition to middle-income status, demanding improved healthcare services. Access to neglected tropical disease interventions are also an integral part of UHC, particularly in Africa, and here the private sector has also played a crucial role through commitments such as the London Declaration. We are a natural solution partner to governments and patients. Given the complexities associated with UHC, we encourage governments to explore working through public-private partnerships focused on a wide range of areas, from health literacy and health system strengthening to access to quality service and financial protection schemes. We believe that UHC will only be achieved after a process of learning from experiences and evolving innovations. Such processes will produce the best healthcare models, tailored to the need of each country instead of a one-size-fits-all solution that potentially limit growth. A strong health economy based on country self-sustaining model consistent with national economic development goals is essential to ensure a sustainable system, independent from development assistance. We stand ready to work hand in hand with governments to support new models of health financing and delivery that are adaptable to local conditions. Thank you for your attention.
Thank you, Cynthia. I will now pass the floor to Dr. Jeremiah Mwangi to make a statement on behalf of the World Heart Federation.
Thank you, Chair. Honorable Chair, Excellencies, distinguished delegates, the World Heart Federation welcomes the committee's report. We commend its recognition of strong, resilient health systems as the foundation for attaining universal health coverage, and the bold but achievable targets it has set in this regard. To help member states honor their commitments, we encourage them to include interventions that prevent and control rheumatic heart disease, or RHD, into essential packages of health services. RHD is a preventable disease which, if not systematically controlled through basic primary care, can progress and cause devastating morbidity and mortality during the most productive years. Acute rheumatic fever and RHD are highly prevalent in this region, with the 2017 study suggesting significant burdens in Eastern, Central, Western, and Southern Africa. RHD has already been identified as a regional priority, with 7 key actions to eradicate RHD set out in an African Union communique in 2015. The economic case for including RHD programs in a package of essential health services for UHC is compelling. Cost-effective interventions for primary and secondary prevention of rheumatic fever and RHD are highlighted in Appendix 3 of the Global Action Plan on Non-Communicable Diseases. These should be considered when weighed against the estimated economic cost of global deaths from RHD in 2010, which was $2.2 trillion. There is also a strong humanitarian imperative to act. RHD disproportionately affects the poor, who often cannot afford care, and women and young children who are less likely to receive equitable access to health services. Let's leave no one behind. To help member states integrate RHD sustainably and equitably into packages of essential UHC services, we suggest the following. Include selected RHD interventions in basic UHC packages, which might include, for example, basic RHD screening in rural areas by non-physicians with support from cardiologists via telemedicine. Interventions can be drawn from the TIPS framework, a toolkit for implementing RHD control programs. Secondly, to integrate RHD interventions into other established disease areas, such as maternal and child health and HIV/AIDS interventions. And finally, to prioritize implementation of the 7 key actions to eradicate RHD as outlined in the African Union Communique. The World Heart Federation reaffirms its support for all member states in the African region as you continue your progress towards universal health coverage. Thank you.
Thank you, Mr. Mwangi. Rheumatic heart disease is a big issue, and thank you for bringing it up. What you do now that you come for work now is we're going to have a break. Come back at 5:05. Work until so please try to eat buns and work until 8. After 8 there will be also there is a real waiting. Let everyone in the room